So I'm Jonathan Borrell with HKS. Just wanted to say a couple of words. Firstly, thank you very much for having us here today. I know that I'm trying to kick off this healthcare program within the University of Miami architectural program is important to you. So we appreciate the opportunity to come here and speak to you. But one of the things I wanted to say is, when I embarked on my healthcare journey as an architect, and I went to university in England, and I got hired by HKS to come to the US, they actually hired me to work in the sports group. I was an athlete most of my life. That was what interested me. So when I got hired, it was to do that, and I got to HKS, and we were just finishing at a big project in Dallas, and they said, just work in the healthcare group for a little bit. Just get used to working in architecture here in the US, very different than the UK. I'll tell you that 6 months after the fact, I saw a project go at Texas Scottish Rite Children's Hospital, from programming to design to implementation, and actually kind of build it. And I did the work myself, and by the time I finished that 6 months after the fact, they asked me to come into the sports group, and I said, you know what, I think I'm really good where I'm at. I really enjoy what I was doing. So, from that, we've kind of worked pretty much all over the world and had opportunities to work, as we mentioned, in places in the Caribbean and South America, as well as in the United Kingdom, and all the places have very, very different ideas of what healthcare really needs to be. Some of the metrics that we have, the importance is not necessarily about the numbers. The importance is that a lot of the stuff that we do is related to either some of the projects that we look back in and see what did we learn from some of the things that we've done, and then how do we push the boundaries and how do we move that forward? Because without the research component, all we're doing is actually mimicking what we've done in the past, and we have to really kind of push those boundaries to be able to say, what is the healthcare of the future? How do we move this thing forward? Yes, it's a building, but it's a living building, as Pat had mentioned. There's a lot of things that go into it that that inform us, in our daily lives, and it's no longer a place that you go when you're feeling sick. There's that engagement to the community. Pat also mentioned that we feel that it's so important to be part of that community, that people can actually feel they can come to this facility and actually be part of of something bigger, that it's not just hey, you're sick and you go and you get treated. Some of the things that we have within HKS, and HKS is a big firm, worldwide, just like any other firms here. But we started, a Knox group that is really kind of, looking at operational planning and how the improvements, we could do within the facilities. But also, within that, there's the MDs, there's, registered nurses as well within that team to be able to inform us, just not on the medical side, but also like on the architectural side. With that, we also, have a non-profit entity within HKS called Cadre, and, which Upali will be talking a little bit more about. But really what it does is really give us a wider range of being able to access different facilities and look at what that research is in different types of environments, different cities, different countries, different healthcare systems within even the US, and be able to kind of give us some information that could be at the fingertips, whether it's writing white papers, whether it's, producing, drawings, or being part of the team as you integrate and you develop and you design. We all talk about integrated design, and that's like the keywords nowadays, right? IPD, lean, everybody kind of throws out those terms. Really what that really means is just kind of really being part of something bigger. It's not just, getting the information, kind of designing a building, building it, and then handing it over. There's more that kind of goes into that. It's not just, about, looking for those opportunities to be, to really push innovation. But with innovation comes, change, and what does that change really mean? And, is that a meaningful change? Are we going backwards? Are we going forwards? What are we doing? Are we in a stalemate? And those important things really kind of start to inform how the building really needs to kind of be designed. Yeah. So some of the keywords, again, that you'll kind of hear is that evidence-based design. But, there's other things as well. There's the knowledge base. The knowledge base is all the projects that you've actually done in the past, and you kind of look back and say, well, what worked well, what didn't work well, and why didn't it work well? And that's where the research component kind of starts to come in. And that's what really kind of drives the innovation, right? Is, we have a set of parameters that we designed the building around, but now that you have a new set of goals, a new client, a new vision for something special, it's not just let's design something that we've done in the past. even within their own system, it's, how do we push the boundaries, how do we get better? And, get better, pushing the boundaries is what we're all about and what excites us. With all this, information in terms of research and design, really what we're trying to do is just get better outcomes. There's a lot of, research done in the past about, infections at facilities, people getting the wrong medication. All these things are avoidable, if we start looking at, why those things happen, analyze those things, and, start going through a process of this kind of 5 why thing, which is the lean tool, which is, asking questions as to kind of why, to be able to get to the root cause of the problem. If you can't get to the root cause of the problem, you can't find a solution to it. And all you do is perpetuate the design that doesn't work in the first place just because somebody's saying, well, that's how we do it. There are a lot of articles that are out there. They're on the Cadre website. They're published. They're around, white papers about all different types of aspects of the healthcare. But it's all really kind of relating back to, health outcomes. How do we get better? Those research papers are not just to say, here's a historic paper of, something that was done. Is, okay, well, how do we turn that and turn it into architecture, and how do we kind of improve upon that and actually move it forward? Most of the things that we kind of look at as well when we think about hospitals is, as opposed to, some of the other, market sectors like, sports, corporate, commercial buildings, they're not necessarily, concerned with the nature views and stuff. Yes, it's important to incorporate that into the buildings, but the reality is that you're there for a different purpose. Well, when somebody is ill and somebody comes to a hospital, what they want to do is to be able to be treated. Well, when they're treated, that just doesn't mean, get a Band-Aid and you're out of the door. Some of those people actually stay there for a long time. So what does that really mean? What that really means is that you really need to make them comfortable. Making them comfortable means, having access to daylight, having access to sunlight, being able to kind of be a little bit mobile and be able to be moving around, because all those things just kind of help them get better and actually want to be able to go home. A lot of the things that we also talk about again is infection control. Infection control is not just, okay, so I'll wash my hands and it's kind of nice and clean. Well, it's about, treating the patients that you're looking at, whether they're a cancer patient and immunosuppressant, and you can't, that interaction, but it becomes a little bit different. You still have to, look at, materials that you use, because, bacteria does grow on materials, so the selection of materials starts to become important. And then obviously the daylighting, and that daylighting to reduce that sort of kind of depression that people kind of fall into. I mean, there's obviously a statistic that people that whether it's in England, or it's predominantly grey most of the time and rainy, just like it is in Seattle, that people are seem to be a bit more depressed in those areas than some of the others that have sunshine. Why is that? Is it just the nature of the environment they live in, or is it a nature of the fact that have access to sunlight? And I can tell you that and most of you know that. You wake up in the morning and you look out the window, when you see that sun kind of beating down, you think, oh, today might be a great day. You wake up, you open your curtains, and it's gray, it's wet, it's cold, and you probably don't think that today is going to be a great day. So there is psychology in that. Some of the stuff that we look at related to research is, there's obviously a lot more, but just 5 points here of the things that we kind of look at. And it's obviously, it's the improving that patient and that kind of family experience when they come and they get treated. Kind of Pat touched upon it as well, which was, it's not just about the patient and treating them, and you can have the best healthcare in the world, but what is the experience for the family as you come in to visit these people? Some of them are in rehab hospitals that might spend months and months and months in this facility, and so the family is going to come. They need that family respite, that family kind of break area where they don't have to be necessarily in the patient room to be able to still visit their loved ones. Safety and risk. I mean, we all talk about it. We all talk about materials that we select, and the fact is that people slip and fall, and there's risk in that. We have to improve the safety, not only about the materials that we use, but actually the way that nurses actually dispense medication. You don't interrupt a nurse or a clinician when they're actually dispensing medication. Why? Because you don't want them to make the mistakes. When we look at the effectiveness of the staff, it's the same. Just because you work there doesn't mean that you also have to be able to kind of live in this building and be able to enjoy the amenities that it does have. And then when you start looking at materials, yes, infection control is big. The mitigation of safety, and then people people slipping, but you're also looking at life cycle costs now. So regardless of whether the building is a LEED credited, LEED certified, LEED platinum, silver, gold, whatever you want to call it, and depending on which part of the world you're in, we're still responsible, morally responsible as architects to be able to actually choose materials that are environmentally friendly. Not just because it's required by LEED to be able to obtain a point, but it's because I think it's our duty to do that. And with all these things, and you start looking at these 4 items in front of that, ultimately what you do end up is a building that is a beautiful building, because design is obviously part of it. We're all architects, we all love beautiful design buildings. But it's all about outcomes and being able to have that experience of arriving at this facility, being treated, and then leaving, and then knowing that at some point you're going to come back, and it's not just coming back because you need to do any rehab, but it's because of that community engagement that you might use those community amenities, conference rooms for client education, patient education. Mothers having babies will come back and take classes. So all those things become important in terms of how we design. And you start looking at all these things that we talked about. We talk about air quality, we talk about patient rooms, hand washing, daylighting. You think of this as a beehive, and to get that honey, it all has to work together. It's not just about having a couple of pockets of things that that you actually kind of throw out there and say, oh well, this is kind of great. If it doesn't work together, if it's not integrated, then you don't get the honey that you want at the end of it, right? And that's what you're looking for. And with everything that we do, in whether it's healthcare, any building typology, there's always a give and take. There's the wants, there's the needs, and then there's the desires, right? And most of the time when we do work, it's not necessarily a brand new greenfield building, it's actually renovation within an existing building. What does that mean? That means that there's a certain amount of square footage that we're dealing with. Well, there's 10 pounds of sugar in a 5-pound bag, right? And we all kind of always face that when we design. And so, there has to be that sort of negotiation and that trust between the client, the architect, and the team itself to be able to say, okay, well, what is it that you need? Why is it that you need it? We plug in the research and say, well, this is kind of what we see. Here are some of the trends that we see. Did you think about this? And then be able to negotiate, what, the best outcome for that design kind of needs to be.
Very true. So, before we go further, just a quick show of hands. How many students do we have? Okay. Practicing architects? Okay. Anyone from a healthcare system? Okay. And one way of thinking about it is that each group and each individual in that group comes with a series of lenses. And so the same information that is going to be presented, you'll see it differently. Just something to think about, that one way of having a research integrated approach is to sometimes switch your lenses. And so for students, I would encourage you to go through the rest of it thinking like a practitioner. For practitioners, I would encourage you to think like a student because they still have the idealism. And for owners, I can never tell you what to do, but it's always an interesting exercise for us to go through. So when Jonathan was talking about trade-offs, we find it very interesting when we get research and we integrate it into design. And I loved your presentation, Pat, because you put it in a very broad view. And oftentimes when you start getting into the micro scale, it becomes difficult because you have these trade-offs and you're trying to make these decisions. So one thing that we have started doing, and one thing you'll notice about our presentation is that it's very process-focused. We're going to talk about the how. We heard about the what and the why, and this is going to be a little bit about the how. And so what do you do when you deal with trade-offs like this? What do you do when you're in the thick of a project? You had a brilliant vision. You had a really good idea of what you want to do. You have an image in your mind of where you want to get, whether it's in terms of business outcomes or in terms of the architecture. But then you get into the minutiae and you struggle. Right? So one thing that we have started playing with, and this is incredibly blurred, I think, but the idea is, can we document intentionality throughout the process? For everything that you do you have a strategy, and is that strategy because of a certain rationale? I am putting single patient rooms because of this. I am putting hand washing sinks here because of this. I am doing this particular layout because of certain solar simulations. Can I document that rationale? Can I then say that this rationale is based on evidence, it's based on user feedback, it's based on precedent, it's based on best practice, it's based on code requirement? And think of that, if you work in Revit, as layers that you can turn on and turn off. Right? And that's what we're trying to do. We're trying to integrate that information into the Revit platform. So when I'm working on a design, I can click on a layer and say, this is what code requires me to do. But that's not enough. I go to the next level and say, okay, what are my users telling me to do? Then I go on the next layer and say, okay, what is best practice telling me to do? And then I go to the highest level and say, what is supported by evidence? And if we can get there, but mostly the evidence doesn't catch up to innovation that fast. You may have a brilliant new idea that has not been researched yet. That's okay. As long as you have the rationale documented, as long as you know that this is why I did what I did, we can go back and say, this is evidence supported, or this is an opportunity to collect new evidence. And so it becomes really simple. If we can take all of that back to the platform that we work on as designers. Again, thinking about the micro scale, so you think about the building, you think about how we can make it breathable, how we can make it responsive, how we can make it responsible. And oftentimes, as a field, we struggle with the fact that our technology has moved so fast, but the integration of the human experience still becomes a challenge. So I'll show you this little animation. This came from some field research we did in a med-surg unit, a relatively recent med-surg unit. This is a quick animation. It's a 40-bed unit. You're looking at 20 beds on one side of the pod. This is one nurse's experience based on one pill that she had to give to one patient. Okay? So the patient calls the nurse goes to the patient room. Here, the patient needs a pill. She goes back to the med room and gets the pill. She goes back to the patient, gives the pill. The patient says, I'm feeling nauseous, I think I need to have something with it. So she goes to the other end to get him applesauce to have with one pill, right? We're still on one pill. She goes back all the way, gives it to the patient. The patient takes it, says, I'm still not feeling good, I need some more ice. So she goes back again, gets him some ice chips and water. Comes back again, gives it to the patient throws up. She goes in, gets some supplies, cleans him up, goes into the linen closet, gets linens, comes back, patient's changed, takes the dirty stuff, goes all the way to the other end to put the soiled. One event, one patient, 5 minutes in a nurse's life. Look at the amount she walked. Design did this to her. Design is solely and wholly responsible for how that happened because of how we decided to put our supplies or how we decided to locate spaces. Sometimes we don't realize the potential of what design can do, but if you use the theater analogy, you have actors, you have a script, you have a play, it all happens on the set, and the set is architecture. So if the set doesn't work, it's not going to work. And we always share this, and Jonathan was telling me that was it for Jackson? I can't remember which project.
Memorial. So we actually used this when we actually had that visioning session and actually kind of talked about this. They had a unit that they were going to expand vertically. So the footprint of the building was the footprint. It had limited storage in the middle and the core. And the wings that came out were, double-loaded quarters, but they were just patient rooms with no support space. And they said, well, how can you make it better? I was like, well, there's not a lot we can do physically in terms of moving the building. We can't expand it. We're just growing this thing. It's a 40-bed unit. So we talked to them about the applesauce and the importance of some of the adjacencies that we need to do. So we made some changes to the floor plan, still kept the 40 beds, but actually gave them the support space where they needed it. So, they were short on nourishment stations, they were short on staff toilets. Well, when it's a 40-bed unit, you have a lot of nursing staff, and you have one staff toilet, and the next one is actually outside of the unit and the staff lounge. That's not very practical because, just like Upali was saying, is that nurse already walks miles and miles a day just for that one pill. Or that nurse oversees 3 or 4 patients, depending on the acuity, whether it's med-surg, ICU, or whatever it is that nursing ratios are. But that's a lot of walking, and it's unfortunate that the nursing population is only getting older. They're struggling to get their young people to come in. So as they get older, we're making them walk longer.
And the funny thing was that this became for us the applesauce moment. Because it wasn't the walking that they struggled with. They struggled with the fact that they had to go from one end to the other end for something as minor as applesauce. So it was a really small thing. It's the value of the walk. And sometimes you're willing to walk if it's of value. So our applesauce moment of all the different things we found, this was a very, very tiny thing that somehow resonated. And we also started making sure that our nourishment, meds, and supplies were always co-located. It's something that we hadn't thought about before. On the technology side, what we also did was we took that information on human behavior and we put it into Rhino and Grasshopper models that could plug into your Revit model, so you could simulate these scenarios of how users work in real time while you're working on your designs. So it's something simple like this. This is a heat map. It's generated very, very simply in like 15 minutes. It's all your patient rooms on one side mapped against all your support areas on the other side. So you can do an apples to apples comparison, whether you have a rectangular unit, an L-shaped unit, a trapezoidal unit, or freeform unit. You can generate the exact same graph for them and say, okay, how do my units compare in terms of proximities? So this eye chart, my apologies, it's difficult to read. But this project became really interesting because here we really went, this was ProMedica Tower, we went from research to results. So the research on the front end was doing field research and parametric analysis. We do all the research around human behavior, we do all the research using simulation around building behavior and material behavior, but we have to eventually link it to our tools as designers, which is usually with Revit, Rhino, Grasshopper. I always call it the animal farm. It feels like a new animal comes up every 3 days. And the kind of technology we use, like we look at walking distances, heat maps, user experience, space utilization, patient monitoring technology. We did parametric design so that take the information, put it directly into tools, but also use the tactile tools, mock-ups, decision-making tools, so people can see it full scale, because not everyone visualizes with the sophistication of an architect. Some of the outcomes that we had just from the simulation and using the parametric design tools, although the floor plate in the new unit was double the size of the existing floor plate, based on how we simulated scenarios, we predict that the walking will be reduced in half. And the walking will be reduced in half because of how spaces are laid out, where supplies are, where meds is, where your point of use of everything that the nurse needs to do is, and what that let us do is have more healing spaces that can be more regenerative. So you're not just solving a problem. Once you get functionality taken care of, you can go to the next level. If you don't get that taken care of, you're kind of in that same mire for a long time. Again, why we could spend the time on it is because we could go back and say, look, this is really about the business case. If you can reduce less walking and less wasted walking. Walking is good, right? If it's for health. Walking is good because we're all wearing fitness devices. Again, show of hands, how many people are wearing a fitness device? That's surprising.
That's because they're all nice and young, though.
Yeah, or poor. They will get cheaper, so you'll have more people. But again, walking is a good thing if you're doing it for the purpose. If it's wasteful walking that's stressing you out, it doesn't work. So looking at what walking does, if there is less nurse fatigue, if there's less absenteeism, if there's more nurse satisfaction, if there's lower turnover, you can make a business case. You can make a business case if there's more patient monitoring. If she's walking less, she's spending more time at the bedside, she is monitoring the patient more, fewer falls, again being able to make a business case. So the point that Jonathan was making, eventually we need to be able to articulate how anything that we do eventually helps the organization become better, and that community become better, and that entire ecosystem become better. We're going to skip through this just because it's a slightly blurry image, but again, from ProMedica, this was one of the solutions. Everything that you see as a design strategy, we can go back and tell you exactly why. Why is there glass over there? Why is it open? Because we want collaborative team care. Why is there glass? Because the noise levels were 65 decibel, our target is to get it down to 45 decibel, so we put glass over there. Why are there lights that are responsive on the side? Because we realized that auditory distraction was what was really a big issue with them. We said, let's use visual indicators. So again, if I can do this and eventually come up with a design where every element has intentionality and has an outcome related to it, we have achieved our purpose. So our process is really gather the information, go on the field. Healthcare is such a field that you cannot understand, you cannot be empathetic to it unless you have spent time there in the trenches with the people. It's really, really important. So do the field research, and then take it to the next level. Have the ability to simulate scenarios. We can simulate building, we can simulate daylighting, we can simulate throughput, we can simulate user behavior. Technology allows us to do that if we have the intent. And it really doesn't matter what label we use, evidence-based design, performance-based design, data-driven design, maybe it's just about good design. It's really about good design at the end of the day. And then finally, when you open a facility, commit yourself to evaluation. Commit yourself to going back and testing, did it work? We have a functional performance evaluation that has been in place for 8 years now. So we are constantly gathering data, and it's always interesting how we make the same mistakes again and again, a lot of times. So we're doing it, we don't have it exactly right yet, but we'll get there. To sum up, really what our process is, what we struggle with, like when Jonathan and I work together, or anytime we're working with design teams, is what does that mean at the end of the day to how you can integrate into a real process? So what you see on the left is concept design, SD, DD, CD, CA, all the steps that we talk about traditionally. What you bookend it with is informing design on the very front end and confirming whether what you thought would happen really did, or if you can go back and restart the innovation loop. So for each step, we said, when you do visioning, establish targets. See, these are the outcomes I really want to impact. I want to be the #1 healthcare system. I want to have these kind of outcomes. Identify targets for the client, and then identify targets for the building. So I loved the performance data chart. That's kind of where my eye went. But again, the fact that you can put targets for a building and say, this building is going to sustain itself. This building is going to give more to the community than it's taking. So put those targets right up front. When you're doing SD, give yourself time for exploration and experimentation. During SD and DD, define. And that's what we meant with the intent documents that link every design strategy to a very specific reason, to a performance hypothesis. I'm doing this because of this. One advantage that we've seen is that these live like legacy documents. If your leadership changes over, if new people start coming in, you can still go back and say, look, this is why we did it. This cannot be value engineered out. It has value. An intent document adds a lot to that. So that's the definition phase. Oftentimes we skip that. We do so much exploration, brilliant experimentation, but we forget to put it somewhere where we have clearly defined that this is what I did and why. And this is what I commit to seeing in terms of outcomes when we finish. Measure, unless you have a baseline, unless you know how a system is doing today, you can't tell whether it improved after you did a new building. So it's really important to measure continuously to the extent you can. Monitoring during construction administration, the number of things that get value engineered out happen because no one is monitoring during that phase, and eventually testing, which is after occupancy, going back and evaluating. So it's a very simple target to test methodology. When we talk to the designers, I was talking to Heath the other day and we had the same discussion. Our design team also has a process, and that looks very fluid, and we always have this push and pull saying, design is not a linear process. You cannot put it into this streamline, this, then this, then this, then this. And my response was, I absolutely can, but it is a very theoretical structure. So what you do is each step actually has an iterative process that it goes through, but each deliverable has a research deliverable associated with it as well. So you kind of do the linear and the cyclical simultaneously. The priority is very similar to what Pat was talking about. You want to optimize operations, you want to enhance experience. So it's really about building health, user health, overall well-being. You want to reduce waste, you want to increase well-being. Again, very, very simple priorities. This is our structure, so we have a lot of people from the Miami office in the room as well. The intent is that research cannot live under the aegis of researchers. We're just not smart enough in the real world. So what it really needs to be owned by is the practitioners. And so our structure is that we have anchors, which is the research director, interns, subject matter experts, one person who works entirely on functional performance evaluations. Then we have connectors, the knowledge management people, the people who deal with transferring knowledge. And then we have the research practitioner node. And this is a team of people who spend a percentage of their time on research. They're not trained in research, but I'm going to confess that a lot of times they come up with methodologies that are much smarter because they understand architecture better. And that's it. We'll end with this one. Do you want to take that last slide? Yes?
Sure.
No?
I guess just to end very, very quickly, on anything that Upali has been saying is that the idea is that you have this knowledge base, you collect all this information, and if you don't do anything with it, it's wasted. And you could say that we've written 1,200 papers and we've got all this research and it's there, but if it's not accessible to the people that really need it, it's wasted. If it's not shared with health systems that we do work with to help them understand where we're coming from and why we're maybe promoting some of the ideas behind it, then it's wasted. So it really comes back to having that knowledge and being able to kind of share it. And you can't design buildings without having that knowledge base. So we can only do as well as we can with the information we have at hand. And if we don't have that information, we just can't do it. And we just fall back into the cycle of, well, that's what it was done before, so therefore we just kind of go back and do it again. But that's not what pushes boundaries, and I think we're all here to push boundaries.
And so we're going to end with this. I think the big thing about having research integrated design is to ask the right questions. That's what it boils down to. So just a closing thought that never stop questioning. That's really what, if you have the right question, half your work is done. I think there's a quote by Einstein: if I had 100 hours to solve a problem, I would spend 99 hours defining the question and 1 hour solving it. So we'll close on that thought. Thank you so much.